Good afternoon. Thank you for choosing our group to help you conduct your study on the tactics for combating sexually transmitted diseases among adolescents ages 15 to 19 here in LA County. Today we have presenting myself, Caitlin Llanos,
David Zhao,
Beverly Figueroa,
Jasmine Sanchez,
Silex Volterra,
Judy.
Thank you for your help.
So I will be talking about the overview first. We will start with a health topic. We chose the sexually transmitted diseases, also known as sexually transmitted infections. And the behavior is condom use. Population and location are youth 15 to 19 years of age located in Los Angeles County. First, we will talk about the protection motivation theory, followed by the self-esteem enhancement theory, then the social norm theory, finally the social capital theory. Sexually transmitted diseases, STDs, or sexually transmitted infections, STIs, are infections that are passed from one person to another through sexual contact. The causes vary from bacteria, parasites, yeasts, viruses, according to the US National Library of Medicine. There are more than 20 types of STDs. Some examples are chlamydia, genital herpes, gonorrhea, HIV/AIDS, and syphilis. There are more than 1 million sexually transmitted infections acquired every day in the entire world. Each year, there are an estimated 376 million infections. Based on the 2016 STD surveillance report, chlamydia trachomatis CT and Neisseria gonorrhea NG are among adolescents 15 to 19 the most common forms. The CT infection is about 3,070.9 for females and 832.6 for males every 100,000 cases in 2016. And the NG infection is about 482.1 for females and 280.8 for males in 2016. In California, there are 1,446.8 cases of chlamydia per 100,000 and 261.3 cases of gonorrhea per 100,000 in 2017 for teens ages 15 to 19. In the Los Angeles County, there are 1,499.1 cases of chlamydia per 100,000 and 340.7 cases of gonorrhea per 100,000 in 2017 for teens ages 15 to 19. Research showed that rates of risky sexual behavior continue to increase, especially in adolescence. And it also peaks in adulthood. It also found that females have lower initiation of condom use compared with males because they possess less decision-making power, therefore increasing the risk of STD exposures. Here is a video that talks about sexual health.
I'm not in a monogamous relationship, and I just want to make sure that I'm protecting myself.
I don't have a boyfriend, but I do sometimes see someone I like.
I like boys and girls, but I'm not sexually active.
Because I'm sexually active, I get myself tested every 3 months.
I think your doctor is a good person to talk to about sexual health because they can help you as far as doing an assessment of your risk. Your doctor can be a partner in your journey during your teenage years. It's the physician's responsibility to make sure that we take a complete and comprehensive sexual history on all patients. But for teenagers, I do it with every visit. I say, is everything okay? Do we have any needs in regards to sexual health?
Sexual health is about having a positive and respectful and responsible approach to sexuality and relationship. You can't tell if your partner has an STD just by looking at them. Most STDs don't have any symptoms, so a good way to have a safe and healthy sexual relationship is to go with your partner and get tested before you have sex.
A sexually transmitted disease can be passed on from one person to the next through any type of sexual contact, typically penile, vaginal sexual contact, or it may be even passed on through skin-to-skin contact.
I know sometimes people feel that oral sex is much safer, but you still can contract STDs that way.
STDs from
Yes.
oral sex?
Yes.
A person at risk for getting a sexually transmissible infection is anybody who has unprotected sex. We try to, first of all, encourage young people not to have sex.
But for those who choose to have sex, ways to prevent STDs are going to be to use condoms. Amongst teenagers, that's a very common method. But not only using a condom, but knowing how to use the condom.
I had had a sexual experience with my first partner, and I was like, I need to tell the doctor, and I know they're going to ask if it was with a female or male, and I need to be honest. It was scary. My doctor was very cool. She calmed me down. She's like, it's all right. I see that kind of thing all the time.
So when was the last time you had sex?
It was about a month ago.
Okay. Did you have sex with males, females, or both?
Males.
Okay. It's important at the onset of the relationship with the patient to tell them that I know that things may be embarrassing. I'm going to meet you where you are, as you are, and appreciate that.
When I went to a general checkup for my doctor, it was the first time I asked about sex. So I was nervous about asking. And the reason I asked was because I was very curious. She asked if I was sexually active, if I was dating a boy or a girl. And I said, I'm not currently sexually active. I like boys and girls, but I do not have a boyfriend or girlfriend.
I teach physicians all the time about being as non-judgmental as possible, especially when you're talking about sex.
When I spoke to my doctor, I had a negative experience. I had a new partner and we used protection, but I developed like a rash and I just felt like I should go get it checked out. And she looked at it and she said, if it looks like a duck and it quacks like a duck, then it's probably a duck. And I just felt like that was really inappropriate. Like I left the appointment crying because I was so upset. And finally they called me back to get my actual results and they were negative.
If your doctor is judgmental when you bring it up, then you really need to think about if that is the provider for you. When I go into the room, I say everything that we're going to talk about in this room once the parent or guardian steps out is confidential, unless I think that you're going to harm yourself or others. I encourage all physicians to have policies that are posted in their office to talk about what are the confidentiality issues.
Confidentiality is really important because I know that if I were to be having sex and my mom was informed, I would be like, I'm never going to talk to you ever again. So there has to be trust. If anyone finds it hard to talk about sexual health with their parents, then they should definitely talk to a doctor.
Now when I talk to my doctor about sexual health, I really don't have a problem with it because I developed a good relationship with my doctor.
Learning about sexual health and the issues around it make it easier to talk to a partner or partners. The more you talk about it, the more comfortable you get talking about sex. So you can say, no, that's going to put us at risk for HIV, herpes, gonorrhea, chlamydia, syphilis. So let's not do that. Let's do this instead.
As a young person, you have the right to talk to your healthcare provider about your sexual health. You don't have to be embarrassed. Your provider can help you figure out for which STDs you need to be tested and also help you figure out how to protect yourself against getting STDs.
You need to talk to a person who is experienced in health. It's like, duh.
I hope you enjoyed the video and it was informative. Now I'm going to go over intrapersonal level theory of protection motivation theory, which was developed by Ronald Rogers in 1975. The PMT model is used in predicting and changing behavior using two pathways, threat appraisal and coping appraisal, in which includes severity, vulnerability, response cost, self-efficacy, response efficacy, intrinsic and extrinsic rewards, in which all motivate change of maladaptive behaviors. It explains that individuals' cognitive processes that would promote an intent for change in behavior is influenced by both environmental and intrapersonal fear appeals. which impact attitude change and behavior change through a series of the cognitive processes. So in our age group, 15 through 19, you would assume that in order for a teenager to change his behavior, there have to be some kind of fear imposed. Oh my God, I'm gonna get an STD, I might die from it. So this is what PMT focuses on. Severity. Like I said, the greater the fear that the person is vulnerable or susceptible to a sexually transmitted disease due to not using condoms would promote a change in behavior. The same respect and vulnerability, if the person feels that they are susceptible or vulnerable of acquiring STI, they would promote change. Intrinsic rewards, an evaluation of the personal benefit from adopting or not adopting condom use. Extrinsic rewards, an evaluation of the external consequences of using or not using condoms. That falls under the threat appraisal, which is the fear appeals. In coping appraisal, we focus on response efficacy, the positive impact of using condoms that it will have on the person's sexual health. Response self-efficacy, the ability to implement the use of condoms during every sexual interaction to prevent STIs. And response costs, the belief that the positive behavior will be effective in reducing STI transmission. PMT's impact on sexual risk behaviors. PMT has been used in several research studies in attempts to motivate adaptive behaviors to reduce sexual risk behaviors and its consequences. In this study, a sample of 300 women were used in a PMT study to assess the benefits of the social cognitive theories in the risk reduction of sexual risk behaviors, like using condoms to reduce STI transmission. Of those 300 women, 200 were assigned to an intervention group and 100 were in a control group. Upon completion of the study, 200 of those women in the intervention group demonstrated increased knowledge in preventive behaviors and self-efficacy. So in this model, the application of PMT did prove effective. Will they be effective in condom use? Well, they show some strengths. A PMT model, it can predict a behavior and influence change on the fear of the severity and vulnerability. Increase the intention to act. PMT will also utilize the person's fears in directing the intention to change maladaptive behaviors to healthy behaviors. In this case, would be using condoms at every sexual intercourse. Humans are guided by fears and rewards. If we see a reward or level or the fear level are heightened, we'll engage in change. We usually engage in behavior dependent on a reward. Usually adolescents are making decisions based on what rewards they see, and the greater the consequences, usually they will try not to. If we see an adverse outcome, we allow our fears to guide us in the direction where there is less of a threat. Here are the weaknesses of PMT. It does not take a step-by-step approach, so it doesn't meet you where you're at. Sustainability is questionable depending on if the person regresses and finds themselves again involved in maladaptive behaviors. PMT is not matched like this. Now I'll be presenting my fellow colleague, and she'll be presenting self-esteem enhancing theory.
Hi, once again, my name is Lux Walker, but you can just call me Lux. The first time that the self-esteem enhancing theory was discovered was in 1999 by Dr. Kundu. His research involved how people perceive others and themselves, and it also included social cognition. The main factors were motivation and automatic processing. Another research provided was in 2008 by Cedric Kides and Greg, who discovered that self-esteem had a positive preference over a negative self-view. What self-esteem enhancement theory is and what it was used for is for self-advancing or self-protecting, and it's also used by increasing the positivity or decreasing the negativity in oneself. It is mainly used to study motivation and behavior, how the personal and social relationships affect and has improved the individual. There are two constructs to this theory, which are the personal identity and social identity. Personal identity involves what kind of person the individual is, and this would mean what culture they're from, what their hobbies might include. The social identity would ask would be, does the individual even fit into these social constructs, which is their clubs, their schools, and what they are involved in. So the application that the self-esteem enhancement theory was used, it was in partner appraisal and Marshall satisfaction study using recruited married couples from the community. The study used the self-verification theory and self-esteem enhancement theory, but only the self-esteem enhancement theory portrayed consistent results from the experiment, which showed the researchers were that the Marshall satisfaction was greater than when they were viewed more positively by their spouses and themselves. Some strengths the theory has is when participants begin to think and believe in their positive qualities, they increase their motivation and are not dependent on their relationships and their social constructs. Some limitations include when participants are in a situation related to a threat or failure into their self-esteem, because then this would create a difficult time for individuals to seek a positive mindset. Another limitation would include that self-esteem enhancement theory cannot be used by itself. It would also need the other 3 self-evaluation motives, which include self-assessment, self-verification, and self-improvement. Moving on to the third theory, which will be presented by my fellow colleague.
Hello, my name is Beverly. I'm going to be talking about social norms theory. So basically, an overview of the social norms theory is that it examines behavior influenced by perceptions of what other people accept and expect and how they behave. So it pretty much focuses on to understand personal influences at like a proximal, so the people close to you, and then also almost like at a distal influence in order to change behavior and peer influence. Right, so some background and history on the social norms theory. It was invented by Perks and Berkowitz in 1986 to originally address student alcohol use patterns. So it was best known for its effectiveness in reducing alcohol consumption and alcohol-related injuries in college students. So they was mostly targeted to college students around like the ages of like freshman year, so like let's say like 17-year-olds to like 24-year-olds, but more recently they were starting to target a younger population to see if social norms can help improve the behavior of like younger people. So social norms is basically, social norms theory can be measured quantitatively, meaning that they use questionnaires and surveys during their studies to measure and keep track of their progress in interventions. And pretty much they also take a look at their misperceptions, actual norm, and the influence of other norms that people have, which I will get into more in the constructs. Okay, so social norm constructs, there are 3. There are perceived norm, which what we view as typical or standard in a group, the actual norm, the real beliefs and actions in a group, and the misperception, which is the gap between perceived norm and actual norm. So how I like to think of it, how I remember it, So think of it like you're in a bubble and you have like your friend and you guys are talking about a specific behavior such as say condom use in our case. So I might have my own belief about condom use and my friend might have her own belief and also among her other group of people. And the bubble itself is the misperception, meaning like the gap between the perceived norm from my friend and my actual outlook on the part. So some strengths of the social norms theory would be that social norms have been implemented at all levels of prevention, meaning primary, secondary, and tertiary. And the limitations to this theory would be poor data collection and can lead to unreliable data and poor choice of normative message. Participants with their own view, social norm, can question the initial actual norms presented to them and in the interventions due to the misperceptions they hold. So some people might be skeptical about the actual norm because they're so stuck on their own perceived norm that they might actually end up questioning in the intervention, like why is this the actual norm, because they are unwilling to see the gap of the misperception. So the application of the social norms theory was used among a study in college students. So the study was done among college students to help decrease high-risk sexual behavior such as unprotected sex and trying to increase condom use. So the campaign focused on 4 posters, meaning like ad posters posted among campus and like bathrooms or classrooms to get people's attention. And it displayed healthy sexual behaviors in the posters, and that was their primary like way of getting the message out. And so what they found out in this intervention that they did, they found out that the perceived norms were that their peers underestimated STD and HIV testing and consistent condom use, and peers overestimated sexual activity without a condom. And so pretty much people in college were thinking that there was not a lot of people were getting STI testing and that people were having unprotected sex, and that was just the norm, that it was known. But it was actually false because they found out that the actual norm was that there was actually statistically a lower reported incident rates of STIs and unintended pregnancies. And so, yeah, what they found out was that the findings were that they confirmed that there was an over-predicted estimation of risk and underestimation of protective behavior. So then now my colleague will be introducing to you the next theory.
Hello again, my name is Caitlin. I'm going to be going over the next theory at the community level. We have selected social capital theory. Social capital theory basically just refers to the networks, relationships people have in a community. This social capital must be reciprocal in order for the goal to be achieved. So it means that all people in the community must be trusting of one another and must be strengthened through these relationships through that trust and reciprocity. Those 2 constructs are actually the main constructs in our social capital theory. Construct number 1 is networks. Through the connections we have with each other and through one another, we build trust and reciprocity among the members of the network, of these networks. Now that trust and reciprocity is vital and key in the networking actually being done. Next construct is the strength of the relationships that are in the community. The strength of the relationships have effect on the social capital. Going on to the next slide here. So why did we choose social capital theory for our community level theory? First, there's a lack of research involving social capital theory and its impact on health promoting behavior, which means that more research is suggested and needed. So it could be good for the actual field of health behavior. Next, we have the use of social networking to various members of the trusted community via online social networking and word of mouth, which, as we know from our target population, is pretty popular right now via social networking and word of mouth. They're teenagers, so the more information we can get out to them via these networks, the better. Next, we have the ability to create and improve trusting relationships between different social groups. So it's one thing having one teenage girl talk to another teenage girl about condom use, but it's totally another thing for, say, a doctor or a health school counselor to talk to a patient. Those are two different social groups, a health professional and the target population, the patient. So if we have trust, reciprocity, and word of mouth going on between the doctor and patient, where the doctor provides factual, unbiased information to the patient, then the patient is more likely to trust their healthcare practitioner and continue onwards with the health behavior. So the application of social capital theory. Social capital theory has been successfully used to research topics on smoking and diet. These studies do show positive as well as negative health outcomes, which I'll go on later in the limitations section. Like I said previously, there's not a lot of research regarding social capital theory and STI prevention or condom use, but that's always something to build upon. The strengths and limitations here are, let's start with the limitations. Community social capital is not always present along with community self-efficacy. So it's one thing to have the social capital, trust, reciprocity, and networking, but if the community doesn't feel that they are able to go on with the goal or maintain the goal, achieve the goal, then what's the point of it all? So the strengths, moving on, strengths would be to improve trusting relationships. Like I said, we can improve trusting relationships between certain social networks on the same level, and then also on another level with practitioners and different groups of people within the community. It also links relationships and networking to the community. Like I said, same thing. If the whole community, say of 15 to 19-year-olds, trust and reciprocity and then knowledge and networking is all there, then we can build upon that. The theory can be measured both quantitatively and qualitatively using mixed methods measures. Lastly, we'll go back, next we'll go back onto our theoretical framework presented by my colleague.
Hello again. So here we have the theoretical framework. In it are 4 constructs that we pulled from the 4 theories that have just been presented for you. We begin with the behavior, and then that's followed by the 4 constructs, which will ultimately lead to the desired goal, which is safe sex practices amongst adolescents 15 to 19. So we begin with our behavior, which is thinking about condoms. This is where the adolescents should think about whether it's worth it to use condoms or not. Then it is followed by personal identity, which is pulled from the self-esteem theory. There it reflects on the individual and the type of individual they are. So they'll think about, do I want an STD? Am I going to be able to cope with the consequences of having an STD? Then we have networks. That is pulled from the social capital theory. There, adolescents will connect with networks, which are the connections we have with one another through one another. In other words, it's trust. It's like word of mouth. It's I did it and it was great and you should too. Followed by that is the actual norm, and that is from the social norms theory. This is the real beliefs and actions that the group will take and decide to follow through with. Finally, we have the response self-efficacy. That's pulled from the protection motivation theory. This is a positive impact using condoms will have on sexual health and the safe sexual practices that adolescents will adopt. In the end, we hope that this theoretical framework as structured will lead to safe sex practices, and the outcome would be less STDs amongst our 15 to 19-year-olds in Los Angeles. Finally, our conclusion, which will be presented by my colleague David.
So by utilizing the protection motivation theory and the self-esteem enhancement theory at the intrapersonal level, and the social norms theory at the interpersonal level, along with the social capital theory at the community level, we aim to reduce the at-risk behavior for adolescents ages 15 to 19 in the Los Angeles County. We are well aware that each theory has its advantages and disadvantages. Therefore, by maximizing the former while minimizing the latter, we are confident that at-risk behaviors will greatly decrease.
Thank you for your time and your consideration for choosing our group. We hope we have given you enough information to make an informed decision on this health behavior affecting the youth in Los Angeles County, specifically targeting the sexually transmitted diseases among 15 to 19-year-olds in LA County. If you have any questions, you have our email and contact information. Again, thank you for your time.